Hi, everybody, and welcome to another episode of Colorectal Cancer Canada's Tush Talks. Colorectal Cancer Canada is the nation's leading colorectal cancer not-for-profit patient group, and Tush Talks are our video interview series where we talk to people who we think have perspectives that you might be interested in hearing. My name is Carl Benman, I'm your host, and our guest today is Dr. Christopher Booth. Dr. Booth is a medical oncologist and a health sciences researcher at Queen's University and a professor of oncology and public health sciences. He's also director of the Division of Cancer Care and Epidemiology at the Sinclair Cancer Research Institute. Dr. Booth was the co-chair of the Canadian Cancer Trials Group challenge trial of adjuvant exercise in colon cancer, which was just published in the New England Journal of Medicine in June, right? Is that right, Dr. Booth? Yeah. And we're super thrilled to have you today to talk a bit about this, about the research, and about what we can take away from it. But first, how are you doing today?
Good, thanks. Yeah, Carl, appreciate the opportunity to be on the podcast. Thanks for inviting me. Look forward to the conversation.
Yeah. I guess the first thing that I want to talk about is maybe the shape of this research, because we were talking earlier, you said it took you 18 years, it's got over 20 researchers, it's got patients from all over the world. How does a trial like this come together?
Great question. And without using a pun, I would say this was a marathon of a project, and it really was. So, I mean, the backstory is quite interesting. It dates to 2006, 2007, so almost 20 years ago. I was a young medical oncologist. I had an interest in colon cancer, and I was doing a research fellowship here at the Canadian Cancer Trials Group at Queen's University in Kingston, which is our national cooperative trials group that coordinates clinical trials all over Canada, in fact, in many parts of the world. And I had read some early data coming from the United States, observational data, so not a clinical trial, that suggested that people's exercise habits after their cancer diagnosis might reduce the risk of cancer recurrence. It was actually pretty compelling data. There was a few different studies, but it wasn't a randomized trial design, and there was probably many things that were different about people who exercised and those who did not exercise. And so it remained unclear whether their difference in cancer outcomes was from the exercise itself or just from other things that were not measurable. And around that time, there was some discussion in the trials group about running a randomized trial of exercise to improve chemotherapy-related fatigue. But having seen this data that suggested that it might have an even larger effect, we decided to very ambitiously start proposing the concept of a clinical trial testing the question, can exercise improve cancer survival? Now, again, this question 20 years ago was certainly way out in left field, and I was a very junior oncologist, supported by very thoughtful senior leaders and mentors who were willing to nurture and develop this idea and support a young oncologist. And very early, I partnered with my study co-chair and my partner in crime for the last 20 years, Professor Carrie Cournier. And Carrie is a professor of kinesiology at the University of Alberta and really a world authority as a behavioral change scientist in learning how to work with people who have cancer to get them to change their exercise habits and their lifestyle. So Carrie brought the behavior change expertise. I was a young oncologist with an interest in clinical trials and methods related to research. And we started proposing this concept, very, very many years ago.
Yeah, and how did it kind of grow to, across so many borders, and I guess why did it get so big is really the question.
Great question. So immediately, the groups that entirely supported this were the groups of patients and patient advocates. This was information they'd been looking for a long time. In fact, as an oncologist, one of the most common questions I get asked from a patient when they finish chemotherapy is, Doc, what else can I do? And until recently, we haven't had a lot of great answers or good data to guide patients beyond traditional cancer therapies. So this study had tremendous support and buy-in from the patient community broadly across Canada. And it was deemed, seen as being unique enough that eventually, after proposing this a few times to the leadership of the trials group, it was formally endorsed. And the Canadian Cancer Trials Group is funded by the Canadian Cancer Society, and that's where the money came from to run this trial. It was a very ambitious study. As I said, it was the first clinical trial in the world in any cancer trying to see if exercise can improve survival. We needed about 900 patients, and we knew very early on that we would need partners to be able to achieve this trial in a reasonable time frame. And so one of my colleagues from my training at Princess Margaret Hospital was an Australian oncologist, Dr. Jeanette Vardy, and she had just recently returned to her native Sydney, Australia. And from the very beginning, the Australians were very keen to join, and they got their own grant and they joined. And so from day one, this was really a partnership led by the Canadians, but in deep solidarity with our Australian counterparts. And it ended up opening up in 55 hospitals across 6 different countries. The vast majority of patients came from Canada and Australia. And so there were, dozens of oncologists involved, hundreds of nurses, and many hundreds of research staff around the world. And of course, almost 900 patients and their families who graciously participated in a study that opened in 2009 with the first patient going on study. And we presented the results just a few months ago in June of 2025. So
Yeah.
marathon of a project.
It's funny to hear that a reasonable time frame is almost 20 years, but I mean, that is how long it takes to do the job right?
It does. I mean, it took longer than we anticipated for a few reasons. COVID, of course, was one of them, making all things more difficult and slower with, many trials and centers having to limit their activities during that period of the pandemic. But yeah, we can get in maybe later some of the policy and implementation issues. But certainly these trials take time, and I think one of the other lessons that we'll learn as we get into the very exciting results is that there's not many entities or groups in the world that would be able and willing to tackle a question like this. And this is a question, obviously, that matters very deeply to patients and their families. And so I think it speaks to the power of an academic cooperative trials group like the CCTG and funders like the Canadian Cancer Society to be able to run these trials that really are important to advance the field.
Yeah, and I think that's worth kind of underlining for reasons of the world around us. But you mentioned talking about the results. Let's get into those. What are kind of the most salient findings from this? It seems, looking at it, that hey, exercise helps in a pretty big way. But could you kind of walk me through what that is?
That's the bottom line finding. But before I get to the punchline, let me just tell your listeners a little bit about what the patients did on trial, because that'll become important when we talk about what does this look like rolling out into the clinic and to policy now in the real world.
Because they had an exercise regime and they had a sort of just health education regime, right?
Correct.
Those were the two things that were compared.
So it was 2 arms. So it was almost 900 patients with stage 3 colon cancer and high risk stage 2 colon cancer. They had all had standard of care. They'd all had surgery. They'd all finished their adjuvant chemotherapy. And at that point, they were randomized. And so the control group got an informational booklet encouraging healthy eating and encouraging exercise. The experimental group got the same booklet, but got a physical activity consultant, essentially a funded personal trainer for 3 years. And the goal of this personal trainer was to serve as a motivational coach, life coach, exercise specialist, to support the patient to, in the first 6 months, gradually ramp up their exercise and then sustain it over a period of 3 years. So it was a 3-year intervention. In the first year, they met every 2 weeks with their personal trainer, and those sessions were about an hour in length. The first half was really goal setting, reviewing progress, motivational tools, etc. And the second half was a supervised exercise session on a treadmill, walking, or riding an exercise bike. And in the second year and third year was really monthly sessions. And so the target was for patients to increase their exercise by something called 10 MET hours per week. A MET is a unit of energy. And to put it in context, if you and I were to meet up after this podcast and to go for a brisk walk outside for 1 hour, we have to be walking fast enough, we'd be huffing and puffing a bit. That would count for 4 MET hours. So patients could work with the physical trainer to come up with an exercise prescription using any form of cardiovascular aerobic exercise to hit this target. So it would be a certain number of minutes of biking or walking or running or cycling or kayaking or cross-country skiing per week. And this was done gradually over the first 6 months and then sustained over the following 2.5 years. And so patients did a whole bunch of different things, but most patients started a walking program. And they could hit their targets if they went for a brisk walk, again, huffing and puffing, between 45 and 60 minutes at a time, 3 or 4 days a week. So certainly it's a commitment, but it wasn't, training for a marathon or for an Ironman triathlon. It was, it was achievable with the right supports. And so that's what patients were asked to do. Of course, patients in the control group were free to exercise as they wanted as well. And then we followed up with patients very carefully with their exercise levels, and then ultimately with the study primary endpoint, which was disease-free or cancer survival. And so with that, I guess, kind of getting into the results. So it was 889 patients from these 55 different hospitals. The first important finding was that the patients who were given the personal trainer had a substantial increase in their exercise. Interesting, the control group also increased their exercise, right? These were motivated patients who signed up for a study and they also started exercising. But those patients who had the funded personal trainer increased their exercise even more.
Did they have to, just to interrupt for a second, were they able to go beyond the 10
Yes.
MET limit?
Yeah,
That
they could go
wasn't
as
like
high as
a,
they wanted to. They could go as high
okay.
as they wanted to. Within reason, as in a guided way with their exercise therapist. So their exercise levels went up. We also saw important improvements in their physiologic measures of fitness. So tests like VO2 max testing or how far they could walk on a treadmill in 6 minutes, those things also improved. So their exercise levels went up, their fitness went up, their quality of life, and the tool that we use, the patient report outcome we use, was a measure of physical functioning that also improved over the study period. So those are all very encouraging. Like any clinical trial, we have to be aware of the fact that sometimes our treatments, obviously when they're medicines, have a high risk of side effects and toxicity. So we looked for a signal of toxicity or risk from exercise, and not surprisingly, the only signal we saw was a slight increase in the risk of muscle and joint injuries associated with exercise. Um, but it was the survival results that was really the highlight in the headline, and made a lot of excitement around the world. So the exercise program led to a substantial reduction in the risk of new or recurrent cancer. There was a 28% reduction in the risk of recurrent or new cancer. What this translates to is at 5 years, 80% of patients on the exercise program were alive without cancer, compared to 74% in the exercise arm. And this means, another way of thinking of it is for every 16 people who went on the exercise program, exercise prevented one person from developing recurrent or new cancer. So that was for cancer recurrence rates. When we looked at overall survival and how long people lived and their, really their cure rate of cancer, there was also a substantial improvement. So exercise led to a 37% reduction in the risk of death. And so we followed patients for quite a long time. So at 8 years, 90% of people on the exercise program were alive, compared to 83% of patients on the other arm who were alive. So another way of framing this improvement was that for every 14 patients who went on the exercise program, exercise prevented one person from dying. So
Yeah.
overall, it was really quite remarkable to see this data and see the power of exercise as a way of patients feeling empowered to take charge of their own health and working with this personal trainer to make a major improvement in both their cancer outcomes, but also the many other things that we know come with exercise.
Yeah, they're really remarkable findings. Just maybe for context for people, are there any other sorts of medical interventions or treatments that in, I don't know, recent research history have found a similar impact, 37%, 28% changes in like positive outcomes?
Yeah, it's a great question, Carl. In fact, we've been, when we talk to policymakers about how to turn this into, the real world and get access for patients now with this, we've been framing it that way because, in fact, the magnitude of benefit we saw in this trial with exercise is very comparable and in some cases exceeds the magnitude of benefit of some of our very standard good cancer drugs that we use all the time. So I just want to be clear, I'm not saying that exercise replaces those things or is better, because the exercise trial, patients already had surgery, they
Yeah.
already had chemotherapy, so the exercise is adding to that benefit. But when you look across a whole bunch of different cancers and some of our latest drugs that we're using that are quite good, and we look at how large those benefits are, exercise, the benefit is comparable. It's comparable.
Yeah.
So it's certainly something that we believe is, as of now, a new standard of care that we should be an optimal model is that a patient gets referred into the cancer system. They have a surgeon that does the surgery. They get referred to see someone like me, an oncologist, and the system provides the chemotherapy. And we'd like to envision a model where when the patient finishes their chemotherapy with me, I can refer them to a funded exercise specialist who can deliver this intervention over the subsequent 3 years.
Yeah, and it must also be said that like going for a walk is cheaper than chemotherapy in terms of like maintaining. Not to, because chemo comes first and then cancer's gone and then you exercise, but like the drugs are more expensive than going for a walk in terms of maintaining after positive effects.
You're absolutely right, Carl. So this is important because, this is a treatment that has a risk-benefit ratio that's unlike basically anything else we do in cancer, right? The side effect profile here, I don't want to underestimate, people can get some side effects from exercising, but unlike a lot of our cancer surgeries and radiation and drugs, which, they help a proportion of people, but everyone gets a lot of really bad side effects, the risk-benefit ratio here for exercise is very different. So the targets are achievable for patients, they're empowering for patients, but this is highly affordable and sustainable for a health system. So you're right. I mean, a typical new cancer drug costs in the range of $100,000 or $200,000 per year. We're doing a formal economic analysis right now as part of this study, but a back of the envelope calculation, when you look at the number of hours of a personal trainer that would be needed for this, it's going to cost somewhere in the range of $3,000 to $5,000 per patient over 3 years. So this is very affordable. As one of my oncology colleagues joked when he heard these numbers, he said, Chris, this is essentially a rounding error in the monthly chemotherapy budget of most hospitals. So this is something I think that is good for patients, it's good for the health system, and we need to advocate to get these services available for our patients.
Yeah, it's really, really interesting. I guess a question that comes to me is like, when you hear about these sorts of things, a lot of time you'll be like, oh, well, people who can exercise, they have the time to exercise, so they already are in like a better social position where their outcomes are more likely to be positive. How does the research kind of account for those sorts of social discrepancies that can color data?
Yeah, it's a really good question, Carl. And it's the very reason why we decided we need to run a randomized trial, because otherwise the observational data, there is, as I mentioned in the opening comments, there are inherently differences between people who have the ability to exercise and those who do not. So a randomized trial really, because the beauty of randomization is essentially the two groups of patients look exactly alike, except for one variable. At least that's the hope when you randomize patients. But the point that you raise does speak to what we call the generalizability, or how are we going to roll this out now in the real world? Because these were patients who volunteered to go on a trial, and we know that those patients are often different from typical patients in some ways. And we want to make this accessible, not just to people who have the ability and the means to exercise now or as a history. We want this to be available to everyone, just like we want our surgery and our chemotherapy and other essential services available to everyone, which is why we're really pushing for the systems to fund this. And there's a variety of different models that one could consider. But we also really want to make sure that these data are not just celebrated by the oncology community and interpreted as exercise is good for you, tell your patients to exercise, end of story.
Because we hear that all the time.
Exactly.
Yeah.
What the control arm of the study had, right? Basically, they're given a booklet and they were told to exercise. And that's an important message, but we need to go beyond that, because the study showed that actually, the reason that most people don't exercise is it's hard to induce these lifestyle changes. It's hard to change behavior. It's hard to figure out how to get the time in a busy life, juggling family and careers and all the other commitments, especially for someone who feels overwhelmed. They've just finished chemotherapy, or perhaps they've never really had a good exercise program. And so that's really what this study established. It showed that exercise is good for us, but it also showed that if you provide patients with this coach, personal trainer model, with this behavior change intervention, it can actually get people to change their lifestyle, exercise more, become fitter, feel better, and have a better cancer outcome. So the whole package is actually a really important part of this. And one of the very powerful stories that have come from this trial is when we spoke to both my patients and other patients around the world about who were on the study, about what it meant for them. It was that human connection with their personal trainer that was incredibly powerful. They felt motivated by their trainer. They felt in some ways accountable. They didn't want to let their trainer down, so they got out on a rainy day and went for a walk, even if they didn't really feel like it. So there was this sense of human connection I think was really important. And certainly as we roll this out, we're going to want to make sure that as much as possible we're able to replicate those findings.
Yeah. It's it's I think really evident how, like you said, advocating for this could be really positive. And that's, I think, good next steps for groups like Colorectal Cancer Canada, patient groups, to be able to advocate for these policy changes. But for patients today, is there anything that they can or ought to or oughtn't to take away from a big study like this? How should an individual relate to this research?
Yeah, great question. So I think the first thing is they should speak to their doctor, their family doctor, or their oncologist about what would be appropriate for them, because this was a very specific patient population of stage 2 and stage 3 colon cancer patients who completed chemotherapy, et cetera. And so the extent to which this applies to other diseases or perhaps more advanced stage 4 patients with colon cancer, I think at a big picture level, some exercise is going to be good for almost anyone, but it does need to be tailored based on the circumstances and how well or sick the patient might be. Are they on treatment now? Are they not on treatment, et cetera, et cetera. So I think the starting point is for patients who might be listening to this to ask their oncologist. They can, say, I heard about the exercise trial, and do you think that program would be appropriate for me? In the paper in the New England Journal of Medicine and the supplement online, there's, I think it's a 50-page protocol that basically outlines what was done at each of these coaching and exercise sessions throughout the 3 years. So I know that patients are already going to their local gyms and physiotherapists and exercise therapists wanting to start doing this. And so that guidebook or that protocol might be very helpful for those clinicians. We're in the very early days now of starting to think about how can we design online modules to start training more people in these techniques to make this more accessible for patients. So I think at a starting point, speaking to the physician to kind of get an idea about what would be appropriate, and then where it's available, whether it's a physiotherapy at the hospital or the cancer center or a gym or the YMCA, trying to get involved with a group like that, and even at a minimum, just trying to get out and go for a walk most days. And that might only be 5 or 10 minutes at a time at the beginning, but then that could be ramped up as appropriate based on the physician's advice and the exercise specialist advice.
Yeah. We'll put links in the thing on YouTube for people to go find that. And also, if any of our watchers, listeners have institutional access, they could read the journal article. But not everybody does. But there's a brief that's available also publicly. Yeah, I think for me, what I'm curious about at this point is like kind of what is next. Like a big study like this comes out, which has some big findings. What happens now in terms of like validating, repeating, building on this kind of research?
Yeah, so I mean, this really exploded. I think it's been one of the most widely cited or publicized clinical trials, in cancer in the last number of years. It certainly kind of consumed my life, not just for 18 years, but especially in the last, few months. So there's a lot of interest in this. There's health systems around the world who are already working at designing new models to implement this. I think so. The next phase is really to try to change policies, guidelines, and to implement this to make this available to patients. I've had, dozens of emails and letters and phone calls from different clinicians and patients and families around the world wanting to learn more about this. It's been really kind of heartening to read about these stories. So people are getting really engaged. And the other neat part is hearing from the next generation of researchers who are wondering about other cancers. And so they're designing clinical trials to build on this and explore in models of exercise in cancers beyond colon cancer. One of the common questions is or the really big picture questions is, well, how does this work? What's the mechanism by which exercise improves cancer survival? And so over the last 20 years, there's been a lot of work in laboratories that have described several different models and mechanisms whereby exercise can induce changes in the body that promote an anti-cancer environment. So there's changes in metabolism, there's changes in the immune environment, changes in inflammation, changes in the vascular environment, and all of these things likely contribute to an anti-cancer effect. But the patients who graciously participated in our trial provided blood specimens at several points in the trial over the 3-year intervention. And so we've banked those. And so in the next couple of years, we're doing a number of studies to understand what might be the mechanisms driving this. And we're also doing more granular analysis to try to figure out what seems to work the best when we're supporting patients and how can we try to get the intervention to provide the most benefit for patients. So stay tuned in that space, both for more information about the challenge trial for patients with colon cancer, but there's a whole kind of next generation of studies, I think, coming down the pipeline in other cancers, including some studies in ovarian cancer and breast cancer that are also looking at the role of exercise and diet that I think will be reported in the coming months, in the next couple of years.
Very exciting. That is about the list of questions that I have about this research. But I guess I like to ask people is what is something that you would have wanted me to ask you, or something that you think is really important that you didn't have a chance to say or share about this work?
I think we covered all of it, Carl. I guess just to, express deep gratitude to the oncology community and the patient community that allowed this monumental project to go forward over the last 20 years. It's been, a career highlight and just a remarkable experience to be part of. And it's really exciting to, think about what this means for the next generation of patients. I've been a lifelong runner. I ran varsity cross country and track and field through high school and university. And so I've always had a personal interest in fitness, but to see how this could contribute in a real way to the health of our patients has been very gratifying. And I guess kind of the next steps going from here, and this is where, Colorectal Cancer Canada and the patient community can help us, lobby for this to become part of standard of care. And this is the role of advocacy, and I think we can make a big difference together. So thanks for having me on the show.
Thank you so much for joining. And for sort of future updates about your work, where can people find you if you'd like to direct them, maybe?
So we have, I'm the director of a multidisciplinary Cancer Health Services Research Unit at Queen's University, and obviously an investigator at the Canadian Cancer Trials Group, so they can read more about our work at the website for both of those organizations. And certainly we want to really popularize these results and get patients engaged, so there'll be a number of other kind of public events and educational or journal club webinars that patients and families are more than welcome to attend.
Wonderful. And also to folks listening who might be interested in some resources as well. I mean, of course, Colorectal Cancer Canada has a bunch of stuff for you on our website, on our social media, at colon cancer or at colorectal cancer. You can also reach out at support@colorectalcancercanada.com or info@colorectalcancercanada.com to maybe be put in touch with people who can help you access these resources or support groups, specialized resources for dealing with cancer, dealing with post-cancer, as a caregiver, as a survivor, all sorts of stuff. So if you're somebody who's listening to this and thinks this is all very interesting, I want to learn more, reach out to us, and we are here to help you. Thank you, Dr. Booth, very, very much for joining me today. And I've been Carl Binman, and thanks for listening, and have a wonderful day.
Great. Thanks, Carl, for having me on the show.